Hello, everyone. Welcome to today's webinar and happy September. My name is Marguerite Harden. I am the local resiliency officer with the Colorado Resiliency Office. And welcome to those of you who are just joining our first webinar, our Adaptations and Futures webinar series. And welcome back for those who are regular attendees of this series. We have loved bringing you these webinars every 2 weeks since late March, and I am now announcing that we are actually shifting to a once-a-month format. So just as today, which is the first Thursday of September, we will be shifting to first Thursdays at our normal hour of 11 to 12, today's being a special hour-and-a-half presentation, but generally we will be shifting back to an hour. And so our next webinar is on Thursday, October 3rd, and it will be covering continuity of operations planning, and there's already some information on our website about that. So resources are also always being updated to this website you see on the slide. We have our e-newsletter, we have recordings of previous adaptations and future webinar series, we have local government recovery peer exchanges, community adaptations hubs. So I encourage you all to visit that site, and if you miss us during our shift to once-a-month webinars, there's plenty of resources on there. So for today's webinar, I'm really excited to be talking about this critical topic of mental and behavioral health in times of crises. We at the Colorado Resiliency Office have definitely seen a lot of reports and data on spikes in things like domestic violence and substance abuse, crisis hotline calls, and other indicators that really show this critical importance of this topic. So we're really lucky to be able to be working with our state partners over at the Colorado Department of Public Health and Environment, the Office of Emergency Preparedness and Response, or CDPHE, OEPR. And we have Amy and Reed from that office who are helping us to facilitate this conversation. And they're really ingrained in this work, and we'll be quick to tell you that today's conversation is really not about the state, but about the community and the community-focused organizations that they work with on these topics. They were also really great partners for meeting up with the theme of our series around adaptations and futures. So really focusing on not just the immediate response to mental and behavioral health issues during crises, but how we can learn from the responses that we're having and the impacts and the needs and translate that into reshaping our normal and creating a really intentional, better future. So the health workers you'll hear from today are really exemplifying this in many ways, because not only do they have some short-term COVID-related money, but also long-term programs that will really embed mental and behavioral health into communities by community members and really bringing this topic outside of clinics. So without spoiling any more of this webinar, I'm going to pass it over to Amy to kick us off. Thanks so much, everyone.
Thank you, Marguerite. Hi, everyone. I'm Amy Both-Siebert, and it's a pleasure to be a little bit of your MC today. I'm not going to repeat the name and job title that the organization I come from, because there's a reason we have business cards usually. It's a long title, but I'm really pleased to be kicking this off with sort of an introduction to disaster behavioral health, and then the real features of this webinar are our staff and community leads from across Colorado for the Colorado Crisis Counseling Program. Then you'll hear from the National Institute for Human Resilience. And finally, we'll wrap up with our Colorado Behavioral Healthcare Council. And we'll definitely want to spend some time at the end with your questions and answers for us, the presenters. And we really look forward to sort of hearing how you've connected with this webinar. And since you've already taken the time to be part of this webinar, I'll actually go back to the agenda here for a second, Ollie, thank you. But since you've already taken the time to be part of this webinar, let's take this moment to invest in yourself too. So right now, at this moment, find something that feels good to your body that's different than what you've been doing already this morning. You might stand up or stretch gently in your chair. Maybe open a window for a light breeze or have a glass of water. Just do something right now. Because one of the things that we've really recognized is that micro breaks like this during the day are hugely helpful for rinsing a little bit of our mental inertia, whether that was stress or just sort of feeling a little bit stagnated or something else entirely. Now I'll go to the next slide. It also gives you some more mental readiness to participate in this webinar as I and my fellow presenters talk about patterns and resources for individual and community behavioral health during disasters as a part of this Adaptations and Futures webinar series. So we really do want to start with the purpose of disaster behavioral health, and adaptation is a really good theme for this conversation, because the purpose of disaster behavioral health is to increase the adaptive functioning of survivors, responders, during disasters or other types of crises. And we increase this functioning by reducing stress. Disaster behavioral health really doesn't delve into diagnoses or treatments. It assumes that people are generally resilient, but that there are ways to understand our stress and resource our functioning in difficult or disrupted times. Next slide, Ollie. Stress is a natural and purposeful part of the human experience. One of the primary ways our brain organizes itself is to assess the present moment as we take in information through our senses and ask the question, am I in danger? Is something threatening things that I care about? And the fact is that this danger sense gets activated for physical threats, social threats, environmental, or even values-based threats. And generally, if the answer is yes, the cascade of physical, emotional, and mental sort of experiences that follow that is what we tend to understand as the stress response. Many of you may be familiar with sort of the fight, flight, sort of concept of getting ready to do something when we're faced with a challenge. We also add the ideas of friend, which is this notion that in stress we are pro-social and we tend to want to bring other people around us to help us get through a difficult situation, as well as freeze. Freeze is a response that can be adaptive in an immediate moment when there's sort of no way to avoid a threat and we just need to weather it, get through it. The difficult thing is that, or rather to start with, all four of those different stress responses, fight, flight, freeze, and friend, are all purposeful. They are different ways that our bodies and our brain rally energy and attention to help us survive crisis moments. That's really the purpose of stress, is to help us survive and narrow and focus that energy and attention. The challenge, though, with this natural and purposeful stress response is that it responds even when the source of stress is not just an acute moment, but a longer lasting, maybe more comprehensive disruption, much like COVID-19 has caused in our communities. So the issue is that our brains are constantly sort of doing this assessment process, and our bodies are generating this energy to adjust to new needs or routines related to dealing with these different disruptions and threats in our daily living. So consider the things that you and others are adjusting to right now, individually and collectively, maybe due to COVID-19, maybe due to other things that are going on in your communities. What expectations did you have for this summer or even this year that have changed? How might a loss of a job and the steady income that comes with it, or the inability to celebrate a birthday with other people or have a retirement celebration at work, all of those things happen. How do they feel? How are our bodies handling changes to our workspaces? You know, where we sit, how long we sit, what we sit on. We feel that that's energetically demanding. And what changes to the time we spend with other people, whether that's more time or less time, time in person, or in a lot of cases, interacting primarily virtually. How has that made a big difference in your days? All of this is a significant demand on our energy, and that constant attending to threats can drain our sense of well-being. So we need this ability to reduce stress, to discharge and recharge when the stress is not serving us in addressing the immediate threat, and we need our energy for other efforts. Basically, we're just not robots. We don't just reprogram for new tasks and get on with it. We feel life even as we are living it. So next slide. Because behavioral health on a daily basis and in disasters interacts with the functioning of all of us as people in all of the different spaces we move in, there are a lot of different organizations, teams, and efforts that touch this work. And you can think about different levels of support available for behavioral health. Disaster behavioral health mostly exists in these three broader community-based levels at the bottom of this pyramid that you're seeing on the slide right now. Now, these levels aren't completely separate from one another, and one of the big things we talk about is how can we make bridges between them all so that people get the levels of support that they need at different points in time. But in general, disaster behavioral health really thinks about the crisis or the disaster that we are facing as a health factor, that it's affecting everyone's mental well-being, and then the needs and resources that become important to help connect people to. Disaster behavioral health does a lot of psychoeducation and connecting people with coping skills and practices that help them sort of get through those energetic ebbs and flows. We do a lot of work around making networks and expanding sort of the behavioral health conversation across natural community supports and social fabric. We try to build these skills not just in a select response group, but across our communities by doing trainings like psychological first aid or mental health first aid. We really want to see organizations sort of take an investment in the behavioral health experiences of their communities, through things like employee assistance programs for your workforce, or team sort of debriefing practices, especially for teams that work together on a regular basis. And then when we get to sort of that level of, acute adjustment periods like we're facing during this disaster, there are crisis lines and sometimes crisis programs that sort of step up to augment the capacity to sort of reach people with that training, that ability to reconnect people across communities. And that's a lot of disaster behavioral health. Access to behavioral health care and the need to sort of take care of longer or higher intensity behavioral health conditions and needs and concerns among our community is sort of that next level. And again, I work with the Colorado Department of Public Health and Environment, but we are really pleased to have support from our partners at the Office of Behavioral Health in the Colorado Department of Human Services, as they focus on sort of the regular system building for ongoing mental health treatment and recovery. And if we really sort of come to realize that there are concerns in our communities that go beyond the immediate disaster or the immediate ability to sort of adjust and adapt to disruptions, it's really great to have these connections that help us bridge people into longer term care or community supports that will be here after disasters happen as well. And then at that very highest level, we have kind of this acute care of when somebody is in a full-blown, sometimes life-threatening crisis and needs sort of that most high level of care. Across all of this, we really are trying to build a sense of collaboration and especially sort of situational awareness of how we can refer to one another and create sort of warm handoffs and continuity of care for people who are facing behavioral health needs, but also recognizing that we all have behavioral health needs all the time. And much like physical health is not just what happens in hospitals and treatment environments, we really want behavioral health to become a larger part of holistic community health conversations. Next slide, Ollie. So disaster behavioral health as a collection of interventions and sort of programs and just concepts really draw on a seminal article that came from Stephen Hobfall, Patricia Watson, and a lot of their colleagues. They did this huge research review of trauma psychology and disaster psychology and interviews with experts and survivors about what is it that helps you function during disrupted crisis moments. And what they found were the 5 essential elements for immediate and midterm trauma intervention, and just a wide swath of empirical evidence that supported that. In general, if we can promote a sense of safety, a sense of calm, a sense of connectedness, a sense of hope, and a sense of efficacy on both individual and collective community levels, these are the principles, these are the practices that tend to help people reduce their stress and increase their functioning, allow the brain to sort of release a little bit of that narrow and focus energy and focus more broadly again. So you may hear a little bit about, psychological first aid or skills for psychological recovery. There may be some allusion to this in the GRIT program that you'll hear from a little bit later in the webinar. But all of these disaster behavioral health related efforts tend to draw on these 5 major principles. And what we want you all as participants in this webinar to walk away with is not only a sort of curiosity and maybe an initiative to sort of go get connected to some of these efforts in your community, but also ask yourself as a regular check-in, how can I help promote these 5 intervention disaster behavioral health principles in the spheres that I walk in, from that personal level to that team level to organizational level. All of those spaces are really great opportunities to explore this further. Next slide, Ollie. The final concept that I wanted to give as part of this introduction is this idea that we know that there is a pretty typical pattern that our communities go through during disasters when it comes to sort of that progress through a disaster journey and the emotional highs and lows that come with it. There's the impact of when a disaster happens, and sometimes you get a little bit of forewarning about it, but sometimes it just happens, as in a fire or a flood, which is what this pattern of disaster community recovery is largely based on. And I will just acknowledge the caveat that since COVID-19 is a long-lasting and has sort of these ebbs and flows of waves that take place at different times in different communities, it's probably a little bit more complex than this, but this is still a pattern of community response that you may be starting to recognize in your communities. So once there's that impact, we have this immediate, what's called heroic phase. There's a lot of energy, a lot of people trying to get things done in a very fast state, attending to sort of those life safety types of issues. And a lot of times this is effective. A lot of times it's just a whole lot of energy and still trying to figure out what works best. But there's this sense of making the effort collectively and in a very fast manner. And then we spend some time in this honeymoon period. It's a time of strong community cohesion, where we feel like everybody's focused on the same thing. We're kind of supporting one another. We're going through it together. We can do this. And then there's a period of disillusionment. This often tends to coincide with people running out of energy, maybe communities running out of resources, or supports that come in for a specific disaster event starting to pull away. And the way that sort of strains the social fabric, people may be feeling, I'm not back to normal yet. And this is really hard because I see some other people, trying to move on, and there's this maybe less of a sense of connection and more a sense of disconnection. And our desire during this time, which often, sort of coincides with, 3 to 6 months as a starting point and definitely lasts into sort of the 6 to 9 month period and after as well, is to do what we can to help reinforce those senses of connection, both to each other and to resources that are still important to people's recovery journey. And hopefully that helps us get to a reconstruction period when we really are able to start envisioning a new normal, not just a now normal. And we really hope, among all of us who are presenting today, that behavioral health is a part of those new normal conversations, and that gets embedded more deeply into the conversation about how do we live and interact with one another, recognizing that we don't just do things, we feel things as we're doing them, and that requires energy that is, natural and purposeful, and we're all having these common reactions to difficult, abnormal situations. So I want to get this going over to our other presenters. But the final thing that I want you to recognize about that pattern is that while there's a major sort of up and down that you can see, there are also lots of little up and downs. Those happen on a weekly basis, on a daily basis. So again, if we can think back to those 5 principles of disaster behavioral health, how can I use those to guide ways to make the day a little bit better, the week a little bit better, and recognize that even if I'm having sort of a bad day today, there's a possibility of having a slightly better day the next day. So big swings and small day-to-day ups and downs are definitely a part of what we try to focus on in this disaster behavioral health world. Now, I would love to turn this over to a really incredible person and a really incredible program that's going on now as a part of the response to the COVID-19 response, but also leaves a tremendous legacy in our communities. So Reed Floria, our Colorado Spirit Crisis Counseling Program Manager, over to you.
Thank you so much, Amy. Hello, everyone. My name is Reed Floria. My pronouns are they and she, and I will be giving you a kind of general overview of our Colorado Spirit Crisis Counseling Program today before turning it over to 4 of our specific CCP providers. Ollie, can you go to the next slide for me? Thank you. So to start us off, the Crisis Counseling Program is one of several individual assistance programs through FEMA and SAMHSA, actually, the Substance Abuse and Mental Health Services Administration. States, territories, and federally recognized tribes become eligible for the Crisis Counseling Program after receiving a presidential declaration of emergency. Next slide. There are some key principles that guide all crisis counseling programs across all disasters and across all states, territories, and tribes. I'm going to walk through each of these briefly. So the first is that this is a very strengths-based program. Crisis counselors and other CCP staff are never pathologizing and certainly never diagnosing folks that they're engaging with through the crisis counseling program. If they do realize that there's somebody who might need a higher level of care, then they're going to be doing a referral or resource linkage of some sort to an existing community support system for that higher level of care. Another really important aspect of the CCP is that this is an anonymous program. As I'm sure many, if not all of you are aware, there's a lot of stigma wrapped up in mental and behavioral health. And we have found kind of across the country that keeping crisis counseling programs anonymous helps folks feel more able to reach out and get the support that they are wanting or needing. The next 2 principles go hand in hand. So the crisis counseling program is outreach oriented and occurs in non-traditional settings. Typically, a CCP happens after a natural disaster, like a wildfire or a flood, and so CCP teams are going out in person, knocking on doors, meeting folks at community gathering places like libraries or parks or coffee shops, and engaging face-to-face. We're never waiting for folks to come to us as the CCP the way that we usually would in traditional mental health services. That, of course, looks very different this time around in the COVID-19 environment. Although some of our teams are finding creative ways to very safely and physically distanced and with appropriate PPE meet somewhat face-to-face with folks, the vast majority of this program is happening virtually. So you will start to see through both the local providers and us at the state in the coming weeks, a lot of media around this program, both social media and more traditional media, to help folks understand the purpose of this program and how and why to connect. And then finally, as I mentioned, there's a huge emphasis on strengthening existing community support systems. So the teams that exist in this CCP are parts of agencies that have longstanding relationships with communities and community partners across the state. And the referrals that are happening are super critical because that is a way that we are ensuring that the CCP isn't supplanting existing resources, but rather getting folks connected with longer term resources that will exist long after the CCP closes up. Next slide. So the CCP exists kind of for a lot of reasons, but really echoing everything that Amy described earlier about disaster behavioral health. The crisis counselors and other staff are really focused on helping individuals, families, and communities understand their current reactions, maybe the reactions of others, to really normalize those. As I mentioned, we're never diagnosing or pathologizing folks. A huge saying in disaster behavioral health is that people are having normal reactions to an abnormal situation. The CCP and crisis counselors are also focused on reducing folks' stress and providing that emotional support. Sometimes that can look like reviewing different disaster recovery options. Those are a little bit more clear-cut in a natural disaster, for example, when maybe there's housing needs or something along those lines. But there's still a lot of disaster recovery options in the face of COVID that folks can help their communities navigate. Things like how to get groceries if you aren't comfortable or it's not safe for you to go out in person and you maybe don't have another person to help you with that. They also promote coping strategies, and this can look a couple of ways. It could be focusing on what folks have done in the past that have worked for them, but it could also be talking through what some other options are. And finally, as I mentioned before, connecting folks with those existing community support systems. To give you a sense of our timeline, this is a bit of an odd program in that although the CCP is one overarching program, there are two different grants involved and therefore two different applications. So typically a disaster happens, you receive your presidential declaration of emergency, and alongside that you become eligible to apply for individual assistance programs, including the CCP. From the date of that presidential declaration and eligibility for individual assistance, the state, territory, or tribe has 14 days to write and submit their immediate services program application. That ISP, or immediate services program, is meant to last from the date of declaration to 60 calendar days later. And on that 60th day, the ISP is meant to end, and you are meant to apply for your regular services program. That gets a little odd, right? Because you're applying for your next program the day that your current program ends. And so it's very common to have an extension of your immediate services program while federal partners and sometimes Congress are reviewing and hopefully approving your regular services program application. This looks even weirder this time around with COVID-19 because for the first time in the history of the crisis counseling program, all 50 states, at least 4 territories, the District of Columbia, and several federally recognized tribes are applying for and running crisis counseling programs at the same time. So in Colorado, we received our presidential declaration earlier than this, but were notified that we were eligible to apply for individual assistance on April 30th of this year. We had until May 14th to submit that immediate services program, and June 29th to run that program and submit our regular services program application. We have received several extensions of the immediate services program. Those extensions are carrying us through September 27th, and then September 28th, we will start our regular services program, which will last for 9 months. A quick note here, the reason why the ISP is so quick and then transitions to the RSP is because the ISP is meant to be quick and dirty, get things off the ground, and really hear from folks in the community so that you can build out a stronger needs assessment, budget, and service plan for the regular service program, which lasts much longer. that looked very different this time around, with COVID-19 slowing down hiring processes, the slowness it takes for federal partners to be able to review the extraordinary number of applications they have at once. But we are approved for our regular services program, and we'll be starting that on September 28th. Next slide. Here is a map of our regular services program. All but 3 of these providers are with us right now. 3 of them will be joining us on September 28th. And just a note about our providers, you'll be hearing from 4 of them today, and some of them are community mental health centers such as Access Health System that serve entire geographical areas in multiple counties. Access Health, for example, is Montezuma, Dolores, San Juan, La Plata, and Archuleta counties. And smaller, more specific centers that serve particular community groups, like the Center for African American Health based in Denver, who you'll be hearing from today. Next slide. There are 2 other slightly more rare programs that we have partnered with for this particular CCP. One is through the University of Colorado Anschutz Medical Campus and their Department of Psychiatry to help fund a healthcare worker well-being support line across the entire state. The number for that is on this slide, and that is available to anyone who touches healthcare whatsoever. The other is My Strength, and this can be accessed through any of our providers. They have specific URLs to make available to folks. My Strength typically happens alongside psychotherapy, actually, but in the face of COVID-19, they've created a specific module that is really more about coping skills and much more aligned with disaster behavioral health. The activities in there can range from strategies to manage stress or social isolation to tips for parenting or returning to work or school. Next slide. So in addition to the 4 folks you'll be hearing from today and we'll have contact information for, we of course have about a dozen other providers. If you want more information about the CCP more generally or want to connect with a team that you maybe don't hear from today, please feel free to reach out to me and I'd be happy to put you in touch with them. With that, I will go ahead and turn it over to Amber Behrens.
Hi, thank you, Reed, for the introduction. My name is Amber, and I work at All Health Network, and I'm the manager of the Colorado Spirit program there. We're really excited to be able to offer this support to our communities free of charge. All Health Network traditionally serves Arapahoe and Douglas counties, excluding the parts of Arapahoe County that are within the city of Aurora, because Aurora has their own mental health center. So our Colorado Spirit program will also cover those same catchment areas. I really appreciate Amy's overview of what kind of disaster behavioral health is and what the core principles are that we're trying to promote, because that's really the focus of what we want to help spread in our community and help people engage with. So we have 3 folks on our team right now that are actually doing that kind of work. We have our 2 crisis counselors, Sarah and Paula, and a senior care specialist, Ayla, who will be able to really provide some different and more focused support to our older adult communities. We're also working to recruit for a child specialist because we know kids and families are really differently impacted during times of disaster. We are really hopeful that these positions allow us just to kind of do extra support. And as Amy and Reed both shared, the program support we have available right now is mostly through telephone and video conferencing, just because of the nature of the pandemic in our particular communities. Our program is still in the initial stages of startup, so we've really just begun to contact our local businesses, community groups, partner agencies, and schools to let them know we're here and we can provide support. We know, though, that our community is really varied and that we don't understand all the needs yet. But what we've heard right now is that there's really high stress levels related to financial pressures, job loss, changes in work, education, and childcare. We know that this will continue to evolve just over the course of the pandemic and as other things happen in our community and our world. We also know there's additional hardships for folks that are experiencing homelessness. And then just the natural reactions that so many of us have been facing in terms of isolation, feelings of worry, sadness, grief, and loss. We're really looking forward to hearing more from our communities about what would be most supportive and really partnering with other agencies to provide creative offerings as people continue to live with the pandemic. We also know that our communities have faced many past intense events over the past few years, and that these have all occurred in fairly close succession. So we want to really be mindful of how this support helps in that recovery process as people are trying to recover during a pandemic too. Each time these events have happened, we've seen amazing resilience in action, and our team really just is excited to be able to take a flexible approach to identify ways we can help our communities tap into that resilience again. We can offer individual support, small groups, presentations, and we're really just happy to be of service in any way we can. We do encourage everyone to check out our website that we just got launched for some coping tips, calendar of events, and as a way to contact us for information or support. I think just my last thing before we kind of move on and hear from our next community member is just we really encourage people to reach out. Our hope is really to share the message that support is available and that no one's alone, and that we really are striving hard to be flexible. Thank you.
Good morning. I'm Brianna Teeters. I'm a community resource navigator with the Center for African American Health, and I'll just give a quick overview of our CCP plan. So the Center for African American Health primarily serves African American, African, and Black individuals and families, mostly in the Denver metro and Aurora area. Although with our recent switch to remote programming, we have noticed participants being statewide. So our CCP team is kind of broken into primary and secondary. Our community resource navigators will be the primary handlers of any requests or questions that come in, but we do have our senior living health and wellness navigator who will help us with our senior and older adult questions and concerns, and we are looking to hire a early childhood program coordinator to assist in early childhood and family requests. So back when the stay-at-home order was put in place in March, the center created a survey to send out to community members where we got around 500 responses, and they were just broken into these three categories. Concerns directly related to COVID. Community members reported getting tested and not receiving their test results, or it being difficult in obtaining them, as well as there being a very prominent belief that they had a higher likelihood of contracting COVID-19. Financial concerns, obviously rent and mortgage, as well as paying other bills, energy, car payments, access to food, as well as either maintaining their health insurance or finding a new program for coverage. In the realm of mental and behavioral health, there were concerns around either maintaining or finding new social support and connection opportunities. One concern we had from seniors was having training on technology. Many of them hadn't used Skype or Zoom before, so they were looking for some type of program to assist them so they would be able to maintain those social connections, as well as access to mental health care. Many respondents recognized that they probably needed that service, but there were a lot of obstacles in them obtaining it. So overall, the most prominent worry was family financial standing, as well as all respondents experiencing anxiety and worry at least once a day every week, with many of them experiencing at least 3 days a week or more. So that's a quick overview of what we're doing at Center for African American Health. I provided our organization email. If you'd like to get in contact with someone else aside from me personally, we'll send that to the correct team member. And then I've also provided my personal email if you have any questions in the future. Thank you for your time.
Ollie, just as a check-in, we going to
Do a quick 2-minute.
Hi folks, sorry, having technical issues. Let me just play this video now.
Hi, my name is Katie Bryant. I am with Access Health Systems here in Durango, Colorado. I am currently the CCP team lead for the Southwest region. So Reed asked me if I could come and speak at this webinar to give you guys an idea of what the area we serve, the structure of our team, a little bit of our strategic plan, and what the specific needs we're hearing from our communities in this region. So I'm going to do a quick 2-minute overview, and hopefully that'll get you guys what you need. So essentially, the Southwest region covers 5 counties. So we serve Archuleta County, La Plata County, Dolores County, San Juan County, and Montezuma County. And in those counties, we have 9 towns. They are Pagosa Springs, Silverton, Durango, Bayfield, Dolores, Dove Creek, Cortez, Mincus, and Ignacio. So the specific needs that we're hearing from our community, and these aren't in any specific order of need. The first one is food insecurity. We're finding that there's widespread food insecurity in our communities, and the families that are accessing this are families that have traditionally not needed to. So supplies are limited, it's pickup only, and hours are limited also. The next thing that we've heard is there's a lack of services and establishments that are open, i.e. like the public library, for our residents that have insecure housing or no housing. And so the things that those residents used to do to kind of help make their life bearable and provide a lot of coping help for them would be to go to the library and to get in out of the rain and the heat right now, and then in the winter it'll be the snow. And with those places closed and restricting access and all of the restricted access to public places, we're just finding that there's a lot of anxiety and a lot more mental health issues in our community that has insecure housing or no housing. The next thing is that we're finding that people are reporting that they're just skipping their medical and dental appointments because 1, they don't want to go to the dentist. 2, there's limited appointments. 3, they find when they call their doctor or primary care physician that there are limited appointments and they may be telehealth for certain conditions. And so what they find is accessing that, they either don't have the internet or they have it, but they don't know how to use it, and it gets frustrating. So they just report that they're just not going to go. The next thing is that we know that our families are really struggling to find safe and appropriate childcare while schools are not providing that 5-day in-person learning. So I'll also make this statement that I'm sure everyone else is experiencing too, but we're really finding that, families that have resources are bringing their grandma down and she's renting a house and they're putting a pod together. And, if you lack those resources or you didn't come into this kind of on a high note, you just can't afford to do that. So the equity around the childcare issue and the supervision issue for kids is very real here. Then the next thing we're finding is that teens and youth are struggling. They're struggling without routine. They're struggling without structure. They're struggling with social isolation. And then, of course, I'm sure we're not any different than any other area of Colorado, but substance use is up here in Southwest Colorado. And we're finding that people that were getting a handle on it, that were really giving it a go, are really feeling we're hearing a lot more hopelessness. So, for example, we're hearing things like, what does it matter? Like, I was going to quit smoking, but I don't care. Certainly can't quit drinking now. I'm home all day. So those reports are concerning to us, and we want to make sure that we do anything we can to intervene so that they don't become problems later on. So our grant allocation allows for 5 team members. So there'll be me, I'm the project lead, team lead, and I have a data fiscal person, I have a media person, I have a community outreach liaison, and I'll have a crisis counselor. So we will be a team of 5. And since this is a program that was set up to respond to right after a disaster in a particular community, we've had to do a little bit of creative thinking on how we can do any face-to-face interactions that would actually have an impact in that community. So one of the things that one of our challenges is that, as you know, I have nine towns, and the unique part about our challenge is these towns are spread out over a 140-mile region from east to west, and then there's mountainous terrain. So many of these communities, well, 7 of my 9 have under 2,000 residents, and one of my towns has actually just 680. So you can see that what might not work in Denver could work here. So what we decided to do is to essentially, we're going to start blanketing. Of course, we're going to blanket every single town and every single area with as much psychoeducational materials as we can, as much PR as we can do, and really just getting the word out and normalizing what people are going through. And then we're going to take it and we're going to separate it by town. So for example, I'm going to pretend that Pagosa's disaster happened in the month of January. And so our team's going to do a lot of pre-work. We're going to be talking to people. We're going to be making sure we have the right resources. And then we're going to be able to schedule. So we're not just going to drop in and knock on doors, because that wouldn't be well received and it wouldn't be safe. So essentially, we're going to shorten that. We're going to do the whole cycle, but we're going to shorten it per town. We're going to spend about a month in each town. And then we're hoping to do at least 10 to 12 in-person visit days where 3 people, we go out to that small community. We've done our pre-work, so we have our appointments set. We've routed it for efficiency. We'll all drive our own cars. We're going to wear proper PPE. We're going to stay 6 feet away. And because we will have set appointments, we will have screened these. So I feel that we will have a much better opportunity to make sure that none of our CCP team members get in a situation where they compromise their safety or the safety of a resident because we feel like, oh, okay, we'll just come inside, or oh, you can't come out. So those things will be taken care of because we will have screened them. So that's our plan. We hope to be fully staffed by mid-September and up and running by really late September. I hope that this message finds everybody coping well, and I'm open to any suggestions that anybody has. So with that, I will let you go on with the webinar. And I do want to give a shout out to Reed, because she has made my job absolutely so much easier. So when she asked me, would I do a video, I really didn't feel like I could say no. So thank you, Reed, for making this all possible. I look forward to working with you, and I hope everybody has a great day.
Good morning, everybody. I'm Patricia Lovato. I am the FEMA team lead for Health Solutions here in Pueblo. Next slide, please. We serve Pueblo, Huérfano, and Las Animas counties. Pueblo currently has an updated population of 113,662. Huérfano has a population of 7,377, and Las Animas has a population of 2,194. We serve these counties. We have a remote office in Huérfano County and in Las Animas County. So we're working to partner with those areas and some of their local areas, so that way we can just get some more information out. As Amber had mentioned earlier in the presentation, she's getting established, but we're also still getting established as well. Next slide, please. My team, obviously I'm the team lead. We have a hotline specialist, a media and communication specialist, and we just recently hired our outreach specialist. She will emphasize a little bit more in senior care. We will be also looking to add into our team an early childhood education specialist, as well as an outreach counselor. But those we're looking to hire on a little bit later down the road as we see a little more demand. Next slide, please. What are we seeing? So we haven't done as much outreach in Huérfano and Las Animas counties, as we haven't met the remote offices down there, but here in Pueblo, we're seeing an increase in services needed, such as an increase of food, an increase of financial assistance, an increase of medical assistance. We're seeing a lot of isolation in our seniors. A lot of our seniors have began to express that they're feeling lonely, or they're feeling like they're having some bad thoughts, or they're experiencing things that they haven't experienced before. So this is a lot harder for them. And as some of my fellow team members had mentioned before, they're not as acclimated with the technology as we are. So they're having a lot harder of a time in communicating with family members or with friends, or a lot of them used to go to bingo halls. So a lot of that, since it's been shut down, they're staying home and they're just finding it a lot harder. We've also seen an increase in abuse cases. We've reached out to the Rape Crisis Services as well as Child Advocacy Center and the YWCA, and they have seen a drastic increase in services and advocacy needed in terms of children and women and seniors as well. We're also seeing a difficulty in securing medical appointments. It's been a lot harder since doctors have been working remote. Seniors haven't been able to get an appointment as often as they would need to, because they don't have the technology to access the telehealth appointments. And a lot of other people have been having a hard time getting their children in for medical appointments that they've needed. So it's just an increase in everything that we're seeing. Financial assistance is needed, food assistance, and just everything that everybody else had mentioned as well. Next slide, please. How to contact us. Here is my cell number and my email, as well as our hotline specialist, Christy Bowden, and our media and communications specialist, Carly Salas. We also did add a new team member. She is our outreach specialist. She's the one that's emphasizing in senior care. So if you would like her email, it is jenniferk@health.solutions. And we also have a website and a Facebook page, so you can feel free to reach out to those as well. Next slide, please. And thank you.
Thank you, Patricia. We're now pleased to turn this over to the Director of the National Institute for Human Resilience, Dr. Charles Benight, to talk about all of the programs that fall under the work they're doing. Over to you.
Dr. Benight, you are self-muted. There you go. It looks like you're good.
There we go. Thank you. Very excited to be here. Thanks for the opportunity to talk about a programming that we've done since March. We launched it in early April called GRIT, and how that interweaves with the crisis counseling program in Colorado, and in particular in El Paso County. So I'll be talking about the El Paso County method today, and will not cover a lot of other programming that we do at the Institute because of time constraints. But if you're interested, you can always email me. Basically, it's very simple at benight.uccs.edu. But next slide, please.
Dr. Benight, we can't hear you anymore. Are you still there? Oh, it looks like there's a bit of a connection issue. Dr. Benight, we might just ask that you join from a different outlet to improve your connectivity. Perhaps clicking on your panelist link in your email. Thanks everyone for sticking with us through some technical difficulties. Send him a text message now. see. You know what, I might just encourage us to loop back to Dr. Benight. So Frank, if you're ready to present, let's go to that presentation now, and we'll come back to Dr. Benight as soon as his hopeful connection gets corrected.
And I just want to, hi everybody, I just want to check in on time. We're scheduled to be done at noon, is that correct? Or are we going to keep?
At 12:30, this is an hour and a half.
12:30, okay.
Yeah, about 15 minutes.
Okay, so good morning or good almost afternoon. My name is Frank Cornelia. I'm the Deputy Director and Chief Strategy Officer for the Colorado Behavioral Healthcare Council. You see on the screen right now our mission statement, and I just want to call everyone's attention to the first clause there on supporting community resilience. That is a key function of community behavioral health providers, and CBHC supports our members' efforts, as you've heard, to support their communities and to build resilience. Go to the next slide. Just a little bit about who CBHC is. We're a limited membership association we formed in 1967 to advocate for community behavioral health providers. Today we have 23 members that include the 17 community mental health centers. We have 4 managed service organization members. They contract with the Office of Behavioral Health to manage a network of substance use disorder providers. And then we have 2 specialty clinics, Servicios de la Raza and Asian Pacific Development Center. CBHC is mostly a dues-funded organization, member-led, staff-supported. We're a 501c3 nonprofit organization. Our roles are issue identification, policy development. We work to advocate on behalf of CBHC member organizations to support their efforts to serve the people and communities that they serve. You can go to the next slide. This is a map. You won't be able to see the names of all the counties or probably read all the names of the community mental health centers. The important thing in looking at this map is to understand that the 17 community mental health centers in Colorado serve the entire state. Each of them has a service area or a catchment area that they were responsible for, and that's noted here by the different shaded colors. So some counties serve an area as unique as a city. In the case of Aurora Mental Health Center, some serve one county. A couple of the community mental health centers serve up to 10 counties. That's true for the northeast corner and the northwest corner. So next slide. Just wanted to give a little bit of a brief on the history of responding to community need. We often think of Columbine as a sentinel event, and certainly it was, and gained national attention for the efforts that Jefferson Center for Mental Health engaged in to support the community during the Columbine shooting. But we have oral history and anecdotes and stories of efforts by North Range Behavioral Health and the center at the time serving Larimer County to support the communities that were affected by the Big Thompson flood in 1976. So, they're extremely proud of our community mental health center efforts to support communities. Amber mentioned some of the difficult experiences that the Arapahoe community faced, and we saw, the Aurora Theater shooting, the Arapahoe High School shooting, the death of Claire Davis, most recently the STEM school shooting in 2019, and the death of Kendrick Castillo. So the other critical community incidents, CMHCs often respond to suicide clusters in school districts. when a cluster of students commits or attempts suicide, hostage situations, and other tragic events and community emergencies. Next slide. All of the 17 community mental health centers, including 2 of our specialty clinics, are partners in the Colorado Crisis Education and Response Network, or COCERN. COCERN was developed in 2006 as a multi-agency, inclusive, organized, collaborative network for disaster behavioral health response. Disaster behavioral health response is defined as all psychosocial activities which serve to support the individual, group, and community deal with the cognitive, emotional, and spiritual impacts of a disaster. This includes mental health, substance abuse assessment, referral, and victim assistance, and spiritual or pastoral care interventions. What settings is disaster behavioral health most beneficial? Disaster behavioral health response is an important aspect of any emergency response. Interventions are deployed in a variety of settings, including disaster assistance centers, communities or town meetings, shelters, schools, family assistance centers, victim information centers, hotlines and information lines, damage assessment teams, community reentry programs, and so on. What does COCERN provide? It provides coordination, resource management, communications, and credentialing. These standards help support effective response and provide protection to individual agencies and organizations by setting the standard of care in Colorado. The one thing I want to mention about COCERN is that it is different and distinct from the CCP, the crisis counseling program that Reed and her contractors described earlier. Certainly there are connections. Each of the community mental health centers has a dedicated disaster coordinator that is a part of the COCERN network. Some of that work crosses over when centers contract with the state to provide services in the crisis counseling program, but they are distinct programs. How does COCERN how does COCERN deploy? COCERN partners may be requested or invited to provide disaster behavioral health services following a local or community crisis, emergency, or disaster. Response invitation channels include emergency dispatch, local or state emergency management, schools, sheriff, police departments, district attorneys' offices, private businesses, local or state departments of public health, and other response agencies. The next slide. So I wanted to talk briefly, just highlight some of the CMHC efforts during the COVID-19 pandemic. All 17 community mental health centers very swiftly converted to outpatient operations to telehealth in order to protect the safety of the individuals and the communities they serve, as well as the staff members. They continued 24/7 services, including co-responder services, mobile crisis services, and other 24/7 residential services safely. They set up warm lines to support community members. They set up social media programs and supports, and there's a very successful program that was developed by Mind Springs and serving the Western Slope, where they created a Facebook live series. In some instances, presentations on their Facebook live series garnered upwards of 800 views, which is a significant number when you think of the populations living in some of their rural and remote areas. They've delivered food. I think the program in Southwest Colorado talked about food scarcity. During this time when people were quarantined or isolating, food scarcity is an issue, and so our centers have delivered food and medicine and other supplies to clients in their community. They've staffed COVID testing lines to offer individuals waiting in those testing lines resources to deal with anxiety and isolation, or the effects of isolation. They participated in mask drives and have organized PPE for partner organizations. And then, as you heard previously, the 12 of the 17 centers are participating in the CCP program, as well as one of our specialty clinic members, Resiliency de la Raza. Next slide. So, my role in this presentation is really to talk about some of the policy, infrastructure, and recommendations that CBHC has put forward. We've got a process through our board of directors to develop a board policy position. We have a board policy position that supports emergency preparedness and response. The position statement of the board of CBHC is that Colorado must maintain and enhance a coordinated behavioral health emergency and disaster response and ensure the permanency of robust resources for preparedness. Underneath of our position statement, we've got policy priorities. Our first priority, if you go to the next slide, is that coordinated behavioral health response to emergencies and disasters. So CBHC supports the continuation of state and federal programs that coordinate community partners in collaborative response to community crises. We support policies, regulation, and legislation that continues Colorado's CMHC ability to respond to any range of community crisis. Next slide. Under emergency preparedness initiatives, we support to be the most effective emergency preparedness efforts need to be adequately funded to meet communities' needs. We support policies that formalize the CMHC's preparedness endeavors and create sustainability of these activities across Colorado communities. And so, I mentioned that each center as a part of the COCERN network has a dedicated disaster behavioral health coordinator. There's very limited funding, and oftentimes those individuals have wear multiple hats within their organization. They do a great job despite that, but CBHC feels like it's, with the slide that I shared previously, with the amount of community disasters or emergencies that the centers have responded to, that it's time that we potentially take a look at formalizing this structure and really putting resources behind it to support the effort of the CMHCs to support their communities in times of disasters and emergencies. Obviously, right now, the state's budget picture does not look like it can support additional funding, but we will continue to explore options to fully fund and resource this service that CMHCs have long provided as a part of their role serving their communities in Colorado. Next slide. There's my contact information. If you go to our CBHC website, cbhc.org, if you go to advocacy and resources, you'll be able to click on our board policy positions. Our policy position for emergency preparedness is listed under our board policies, and then my contact information is there if anybody has any questions.
Thank you, Frank. It looks like we have Dr. Benight back with us, so we want to take this time running up to 12:30 to allow him to present. And if we have some time for additional questions, do invite everybody to put those questions into the box so we can prepare for that. But Dr. Benight, back over to you.
Okay, thank you very much for that. I'm trying to deal with my phone here.
We can hear you, Dr. Benight. So if you're ready.
Okay.
You sound.
So this is just a quick slide here of showing the GRIP program and where we are with it at this point. We're actually a little bit higher than this now. We're too shy of 900 people who've signed up for the program. I'm wondering if there's a slide above this at all, or is this the next slide? Oh, okay, thank you. So we're actually now in 35 states. We're also moved out into Canada, the UK, and Australia, and there's plans for India currently. Next slide. So what is the GRIT training all about? So this came to me right after COVID hit, as I was trying to explain before. Basically, the idea is that the CCP is designed really as an outreach program. And I've done a lot of disaster research over the years and built actually disaster mental health web intervention systems and so forth. And the reality of the crisis counseling program is that it's limited in terms of its capacity to reach the entire population. Obviously, the idea is to reach as many people as possible, provide them resources and so forth as been described today. The challenge with the pandemic, which I realized pretty quickly, is that this is affecting everyone instead of just a localized disaster situation. So one of the things that we know from the literature is that social support is a big predictor of how people do post-disaster. And what we haven't done yet is figured out how to basically build the resilience of the community within the community itself by training them, by giving them resources that they can then use to go out to their own social networks and basically provide resilience coaching. So that's what the GRIP program is designed to do. I worked with Dr. Joe Ruzek from the National Center of PTSD, recently retired, as well as Nicole Weiss to put this together. And basically the idea is to have training on basic effective listening skills in addition to stress and pandemic response and what does that entail. Obviously using the 5 elements that were described earlier by Amy, thinking about those in the context of what community members need to know about that and how they can understand those characteristics and put them into play with their friends, families, and coworkers. So we also include in the training important technological and human referrals so that at the in these conversations, people have the ability to give resources out. So similar, obviously, to the crisis counseling program with the resources that are available through those. That was really important for us to provide these resources quickly and get them out there. We had an NIMH-funded project that resulted in a mydisasterrecovery.com web intervention system that we've customized to COVID, and it's called myresiliencehelp.com and is available for free to anyone who wants to use that. So we provide that along with other app resources such as Calm, Headspace, and so forth. And then we also, of course, provide crisis numbers for immediate need. The specific emphasis in the conversations, these helping conversations, are basically on strength building and promoting resilience. We make it quite a point throughout the 5-hour free training that this is not meant to create mental health providers in any way. It's meant to create basically resilience coaches. And so we emphasize that as similar to an athlete who sprains his or her ankle. A coach can manage that and put ice on it and so forth. If the athlete breaks the ankle, it's time for the doc to come out and really do some extra work. So we make that point with our coaches, and that's been very effective. Ultimately, the coaches are available to reach out to people they already know, which is a great thing because we often in our response systems have people other people don't know unless you're in a small rural community, which then it could be different. But in general, we have crisis counseling outreach to the community with people that don't know each other. So the GRIT system is really a unique system in that these are people responding within their own social relationships, which really helps grease the skids, if you will, to make that easier. Next slide, please. So the idea behind GRIT, of course, is the power of the entire community. And we've had a lot of success getting coaches to sign up throughout Colorado, in particular El Paso County, but also more broadly. I think we're in most counties except for a handful, a very small handful in the state. So we really see this as a statewide, and obviously 35 states, it's a countrywide program now. Next slide, please. So we saw pretty quickly after we launched the original training and put that up, it's fully automated, by the way, online at grit.uccs.edu. People can go in, sign up for the training anytime they want and go through the videos without having to sign up for a course and all that. They can just do it on their own time. We saw the need for education challenges that were coming and have been there, and now we're seeing a lot of them play out. So we created with Dr. Carolyn Geary a Grit for Ed program that's designed to think about the unique issues with COVID related to the families and educational settings. And the basic change with this within the Grit training is that it also thinks about teams within these educational settings, such as coaches, teachers, staff, who can be trained up to then be a wraparound support system for the child in the educational setting as well as the family. So we've got that up, and we're actually updating that right now due to the changes we're facing now with COVID and the schools sort of opening and closing and opening and closing. And so we're trying to respond to that need now. And that training will go live. I think we're going to do a live training on that and tape it starting next week. Next slide, please. Oh, no. Did I lose you again?
Oh, no, we can hear you, Dr.
Oh,
Bennett.
good. I'm sitting here cussing. That's not good.
No, you're good.
So we also put together a Grit for Leaders program focused on social and economic resilience, and put that out to our local nonprofits as well as small business operations to try to support them as they're coming back from the COVID experience, and working with them to deal with their employees as well as for themselves to be able to manage the challenges associated with all of this, which has been huge for these organizations, as you all know. So we saw the need for that and have put that training out as well. Next slide, please. Finally, we just received funding through CDPHE to work with Dr. Steve Berkowitz at Anschutz to think about the Grit program for healthcare workers so that we can, again, do the same idea, but within a subset of the population that are really on the front lines. And so we're going to be customizing the Grit training for healthcare and creating what would be described as Grit teams within the different populations, such as ICU nurses versus ER nurses, physicians, and so forth. So we'll be working on that and then launching that across the state as well. We have to do this by December, so that's going to be coming pretty quickly. Next slide, please. So let me talk about the El Paso County method. So once you have an understanding of the Grit process, what we did is we formed a collaboration with El Paso County Public Health, NAMI, and Aspen Point to try to think about a creative solution for reaching the population and a population answer versus an outreach answer, which is what the CCP model is designed to do. So we created the El Paso County method. Next slide, please. And what you can see from this slide is the concept. So what we have are the crisis counselors that are all trained within the crisis counseling model. And then we have what are called Grit ambassadors from NAMI. So NAMI in El Paso County, they have a host of already outreach coordinators within the NAMI system. So they're used to talking to people, they're used to reaching out, and they're serving as sort of a mediator or a conduit for the Grit program and for the crisis counseling program to then interact with the actual multitude of Grit coaches that are spread throughout the community. And that way we end up with an up-down or back and forward flow of information and support that really should create an exponential community impact way beyond what our original crisis counseling programs can accomplish. And of course, this is differential relative to settings. Obviously, when we think about rural settings, you have less of a population to draw from, but this doesn't mean that a Grit training could not be useful for rural communities that could then interact with the crisis counselors. So I really think we need to start changing our view that we have to be the ones that always reach out. We can actually utilize people's natural skills within relationships to boost that capacity and responding capability. So you see in this slide how that is supposed to function, and we also have funding for this through El Paso County Public Health, and we're planning on doing some significant evaluation of this model that we hope to get some data that gives us some sense of how it's functioning. I'll end with the fact that we've just recently done a focus group of about 20 or so great coaches that came together for an hour with us online to talk about their experiences. And what we are seeing is that indeed these folks that have signed up to do this are able to reach out to their own relationships, friends and family and coworkers, and that it's really provided a vehicle to be able to talk about and ask about difficult things like, you know, how are you doing? Let's just talk about it. It's difficult. This whole experience has been really hard for all of us. You know, how are you experiencing it? And then moving into very specific questions around their strengths and capabilities, and you know, topics such as eating, sleeping, and stress reduction, and so forth. So that if you want more information and you really want to dig into it, the training is available for you to check out. And if anybody has other questions for us, I'm very happy to answer those. I'm excited about this because I've been involved around the crisis counseling system for years. I've had meetings with FEMA, and I think we need to sort of revolutionize that system, if you will, so that we're not doing it in this every disaster we re-stand things up, because these grit coaches will be available and are embedded in the community forever, unless they move, of course. But that creates a much stronger systemic capability than what we have with this sort of stand up, stand down, stand up system. So I'll be quiet and wait for any questions. Thank you for being patient with my internet. It seems to only happen when I'm trying to do these kinds of webinars. So thank you so much.
Thank you, Dr. Benight. I think across all of our presenters, we have definitely been hearing about innovations done sort of within the context of what COVID-19 is teaching us in sort of this real vision of seeing not just a disconnect between one disaster and the next, but how do we foster continuous behavioral health support in the relationships with our community mental health centers and the capacity they develop, but also in this whole community approach that really recognizes that this is a capacity that can be built in individuals, in interpersonal relationships, in organizations, and we're all just hopefully leaving seeds and things that will bloom into legacy opportunities to continue to improve. Looking at the questions list right now, there was a request if Frank or myself or Reed could discuss how COCERN and the CCP intercept and work together. Reed, would you like to take a stab at that? And happy to sort of chime in. And Frank, if there's anything you would add.
Absolutely. Hey, everyone. So one thing I want to clarify is that COCERN as a network does not respond to emergencies. It's made up of individual disaster behavioral health partners that could be tapped by their other emergency response partners. So COCERN as a network is much more focused on networking, on building capacity, on training with each other, and making sure that when we do have large-scale responses that include numerous disaster behavioral health folks from around a particular region or even the entire state, that those folks already know each other and trust each other and can work closely and collaboratively on the ground and not run into stepping on toes or any issue like that. So the biggest way that the CCP is connected with COCERN is kind of twofold. So one being that many of our CCP providers are actually already members of COCERN. So they're already tied into that group and can easily connect with the other members and help them understand the CCP and if and when it would benefit them to refer folks to the CCP and things of that nature. The other way is that we have quarterly COCERN meetings that I historically have led for the last few years, although might be pushing that to someone else on the team for at least the the remainder of the crisis counseling program. But one of the things that we're making sure is on the agenda for those is an update from the crisis counseling program, so that if folks aren't connecting with other COCERN members who maybe are participating in the CCP, that they're still able to get the information about where things are at, what we're hearing around the state, and what kind of strategies and plans there are moving forward in terms of CCP providers meeting needs.
Thanks, Reed. Yeah, so again, that sort of spirit of how do we think about both capacity that helps us to surge, outreach, referral, connection efforts during the response itself, as the crisis counseling program helps us to do, but embedding that in organizations that have longstanding sort of preparedness and network building histories with other disaster behavioral health partners. So again, there's this continuity of care and sort of warm continuation of community behavioral health conversations as it relates to disasters and handling the stress of all of this.
Perfect.
Well,
aren't any other questions? Oh, I was just going to say, if there aren't any other questions, I don't see any others coming through the chat. How about you, Amy? Do you have any other closing remarks you'd like to reference before we say goodbye?
Simply that I hope this has inspired a curiosity in folks who have stuck around to get connected with the programs and the efforts that were represented here, as well as to sort of understand how those different levels of behavioral health support are being realized in your own communities. I really hope you'll continue to be a part of this conversation about destigmatizing mental health, supporting one another. There are lots of pieces of this that have foundations in just the lives we live every day. We don't have to over-professionalize every part of mental health. There's a great deal of it that should just be a part of our ongoing health conversations and you know, healthy behaviors that we engage in every day. So when you're in a good space, think about how you can support others with those 5 areas of disaster behavioral health intervention, but also know the power of reaching out, not just for yourself, but if I can share one final story, one of the most empowering experiences I ever had for my own sense of efficacy and taking care of myself was when my immediate supervisor told me he needed to take time away. He needed this respite. And it was in the middle of one of those disasters that you saw listed from Colorado's history. I can't say enough about how modeling the permission to ask for help for ourselves makes a difference, not only in our immediate moment in being able to access things that help us and get us back to sort of adaptive functioning, but the culture that helps promote across our communities. So you all in your own way can be a part of this disaster behavioral health movement, and please reach out to any one of the presenters if you would like more information. We hope this is a continuing conversation. Thanks so much.
Thank you, Amy, and thank you, Reed. Thank you really to all of our presenters from the Crisis Counseling Program, from the National Institute of Human Resilience, and Dr. Benight, who worked through so much technical difficulties to get on here, the Colorado Behavioral Health Council, just everyone. Thank you, all of our attendees, for joining as well. This is such an important topic, as Amy has so eloquently said, and we're just so glad we could shine a light on some of the great work that's out there. So thank you all for participating. We are again having our next conversation in a month. So it's actually the first Thursday, October 1st, not October 3rd. I believe I got the date wrong in the intro, but we look forward to touching on continuity of operations for local governments and how you can plan for crises like this and continue operating. These resources and the recording and the slides and more are on the site that I just linked in the chat. We really appreciate having you with us, and I hope you all have a very wonderful September. Take care.